should we prescribe ACE inhibitors and ARBS in CKD 4 and 5? Hello Dr. Humans, my name is Christine. I'm a nephrologist based in Melbourne and also a medical educator, and today we're going to be unpacking should we prescribe ACE inhibitors and ARBS in CKD 4 and 5. As a nephrologist, ACE inhibitors and ARBS are one of my very favourite drugs of all time. They're right up there with furosemide when it comes to nephrology satisfaction. But that's not intuitive, right? That my favourite drugs to prescribe in chronic kidney disease are the very first drugs that we score off the chart when someone comes into hospital with an acute kidney injury. That's confusing, right? And so what's the deal with ACE inhibitors and ARBS in chronic kidney disease? And the way I conceptualize this is to think about the glomerulus. The glomerulus is basically a little specialized blood vessel, and it has its own glomerular blood pressure. And that blood pressure is needed to push the filtrate through into the tubules to make urine. And this little glomerular pressure is regulated by the afferent and efferent arteriole. And so if we wanted to increase the glomerular pressure, we would open the afferent arteriole and let more blood in, or we could constrict the efferent arteriole, letting less blood escape. And ACE inhibitors and ARBS work on the efferent arteriole, causing it to dilate. So they let more blood out of the glomerulus, thereby reducing its little glomerular pressure. So in acute kidney injury, that's not helpful. We want to stop the ACE inhibitor and ARBS so that the person can regulate their glomerular pressure and recover from the acute insult that they've just had. However, in someone who has chronic kidney disease, who's well in outpatient land and they're well hydrated, this reduction in glomerular pressure is handy because reduced glomerular pressure means the little nephron is under less stress, right? Under less pressure. And so if you think about it, people with CKD have less nephrons than those without CKD, and those remaining nephrons will be working harder, right? They're doing the same amount of work that the whole amount of nephrons used to do. So when we use ACE inhibitors and ARBS in people with CKD, we're reducing their glomerular pressure, which helps to delay the progression of their CKD to end stage. And that is just one benefit of these drugs. They are also fantastic at reducing systemic blood pressure, and they reduce proteinuria. And we know that the more proteinuria someone has, the faster the renal function will decline and the higher their cardiovascular risk. So minimizing the proteinuria is likely to be beneficial to your patient. But when we start someone on these drugs, we accept a reduction in the GFR by around 20% or so. If it's more than that, if it's 30% reduction or more, we'll stop the drug and do an acute kidney injury workup. But at 20% change in GFR, we usually interpret that as just the drug itself, just doing its job. So for the most part, we accept that 20% change in GFR. But when you have very advanced CKD and you change the GFR by 20%, you have a much bigger impact. And as nephrologists, we base a lot of our management decisions, at that late stage of renal failure on the GFR. So typically in my practice, I'll start to discuss options for renal replacement therapy when the patient hits a GFR of around 20 mils per minute. Below a GFR of 15, we'll really start to make plans for vascular access, if they're planned for hemodialysis, and usually at a GFR of 10 to 12, we'll start getting them organised for peritoneal dialysis if that's the pathway they're going down. So that GFR value is important for clinical practice, especially when making care plans for patients approaching end-stage renal failure. And up until recently, this provided a dilemma of sorts. So some nephrologists would take the stance that the RAAS inhibitor was causing a reduced GFR, and so they would take the RAAS inhibitor away to buy the patient more GFR, boost the GFR, and see if we could delay dialysis, keep their GFR higher for slightly longer. Other nephrologists would continue the RAAS inhibitor with the mindset that the RAAS inhibitor was working in the background, continuing to do its job, slowing the progression to end stage, and that if you took it away, you might accelerate the decline, right? And that was particularly true if the patient had proteinuria. So different nephrologists would do different things, and this remained an evidence-free zone until recently. So because of this dilemma, someone did a clinical trial to answer this very question, and that trial was published in December last year in the New England Journal of Medicine, and it was incredibly helpful. Now, I'm not going to go into this in a full journal club style, but I'll link the article below so you can check that out if you want to. I'm just going to sum things up here. So basically, this trial was performed across 39 centres in the UK. They took over 400 patients with advanced CKD, so CKD stage 4 to 5, who were currently receiving RAAS inhibitors, and then they randomised them into a continuation group and a discontinuation group. Along the way, clinicians were aiming for a blood pressure of 140/85, and they were allowed to use any blood pressure medication they wanted, but of course in the discontinuation group they couldn't use RAAS inhibitors. Those were the only rules. So they followed these patients for a median of 3 years, and the primary outcome was the estimated GFR. And basically what they found was that whether the patient was on RAAS inhibitors or not, there was no difference in the GFR at 3 years. So taking the RAAS inhibitor away did not buy them more time before they got to end stage, and keeping the RAAS inhibitor in play also did not buy them more time. And this was the case regardless of their age, diabetes, proteinuria, blood pressure. So whether you continued or discontinued the RAAS inhibitor, across the board, it didn't seem to matter. It didn't seem to impact on the GFR outcomes and the timing of dialysis. And what was really handy about this study is that the median GFR of these patients was 18 mils per minute, and around 29% of them had a GFR of less than 15. So that's really helpful, because if this study had mostly people with GFRs of 29, that wouldn't have been so clear, right? That's not the person that we're having the trouble with, is the 29 mils per minute. It's way down in the weeds with the 20 mils per minute and below. So I think it was a really great study for including these patients that we do actually struggle with. But the other important thing to note here as we come to apply this to our clinical practice is that this study included patients who had well-controlled blood pressure from the get-go, and the proteinuria was roughly around 1 gram a day. Certainly, some of them had up to 2 grams a day, but no one was really in the nephrotic range of proteinuria. So we're not talking like more than 3 grams a day here. So we can't really apply this to those patients. We still don't really know the best way to manage those patients, and I would be advocating for keeping the RAAS inhibitor in play if they're tolerating it, if they have nephrotic range proteinuria. And again, they weren't looking at patients with poorly controlled blood pressure, so we're not going to be applying this trial to patients with very poorly controlled blood pressure either. But those factors aside, I do think this is helpful. So we can use RAAS inhibitors in CKD 4 and 5, and whether we keep them in play or take them away doesn't seem to impact the GFR outcome or time to dialysis. It's really comforting to know that we can stop them, use other blood pressure medications, and the patient is likely to do just as well. And of course, this space in the literature is changing by the minute. Following the SPRINT trial, our international guidelines actually tell us to aim for a blood pressure of 120 systolic, where this trial was aiming for 140. So that's already kind of outdated in terms of our blood pressure targets. And remember that blood pressure target of 120 is to do with cardiovascular benefit, reduced cardiovascular events, and reduced mortality. And also, the SGLT2 inhibitors are all the rage and being used more and more in the CKD space, even in patients without diabetes, in order to reduce proteinuria and delay progression of CKD. And so I expect that the same question of what do we do with these drugs in advanced CKD is going to need to be answered as well. So that's my take on ACE inhibitors and ARBS. In patients with acute kidney injury, you should stop these drugs until the coast is clear. But once the acute kidney injury resolves, you should consider reintroducing these for all of those benefits, particularly in those CKD 1 to 3 patients. These are helpful at slowing the decline in GFR, they're great for blood pressure, and they're great for reducing proteinuria. And in advanced CKD, CKD 4 and 5 patients with non-nephrotic proteinuria and well-controlled blood pressure, we can now say that you can keep these drugs in play or not, doesn't seem to matter, doesn't seem to affect the kidney function at 3 years, so you can just feel empowered to use them if you want to, if the potassium is okay, or stop them and use something else for their blood pressure. Also totally fine. We would expect them to do just as well based on this recent study. So that is all for today. I hope this helps your clinical practice and gives you so much confidence in your CKD long case if you are sitting your clinical exam. And of course, if you are sitting your clinical exam, you are invited to join Rock Your Long Case, the program. This includes a whole tutorial series on CKD and dialysis for your long case, covering everything you need to know, including how to manage the cardiovascular risk factors, dialysis modalities and how to choose one, as well as how to determine if your patient is a transplant candidate or not. It is very juicy indeed, and it will make you feel oh so confident. So if that is something that you need in your life, then come along to Rock Your Long Case. The CKD content is on demand and available to you right now. And our live practice sessions based on CKD and transplant are coming up very soon in early April. So the best time to join is right now, and I would love to see you there. Otherwise, I hope you enjoyed this lesson, and I will see you again soon. Bye.